אני מנהל של טראומה באדלייד, וגם כן אני עובד במיון שמה, ואני עובד בטיפול נמרץ, וגם אני עובד בפרי-הוספיטל ו-Retrieval medicine, שזה משהו מיוחד בעולם, לפי דעתי, וגם כן באוסטרליה, במקום שאני עובד. איפה אני עובד? זה אדלייד, זה עיר גדול, זה יותר מ1,000,000 אנשים שם, ובית חולים שלי שזה בצד ימין, זה טראומה סנטר, זה הטראומה סנטר גדול, הכי גדול בדרום אוסטרליה, ושם אני עובד גם כן, כמו שאמרתי, בטראומה, וגם אני עובד לפעמים בשדה תעופה. אנחנו יודעים שאוסטרליה זה ענק, וזה משהו להסביר את הגודל של המדינה שלנו בהשוואה את המדינה של אוסטרליה, שזה ממש קטן, ובגלל זה על הרפואה זה משהו שונה, אבל זה גם כן זה דומה בכל מיני דברים. אבל בשבילי זה מתחיל פה בארץ, אני עליתי לארץ ב-96, עשיתי אולפן באולפן עציון בירושלים, ואני עבדתי קצת עם מד"א, במד"א ירושלים, וזה ממש טוב, זה הפעם הראשון שעבדתי מחוץ מהבית חולים, וממש פתחתי את העיניים שלי לעבודה שאתם עושים, ועכשיו אני עושה גם כן עכשיו. אחרי זה אני עשיתי 1.5 שנה בצבא, הייתי רופא באגוז, וזה היה 1.5 שנה מאוד מעניין בשבילי, ומשהו לפי הרפואה וגם כן לפי המבצעים שעשינו. אחרי זה אני חזרתי ללונדון, ואני עבדתי עם מסוק טראומה, שזה ברויאל לונדון הוספיטל, שזה עוד פעם, אני עובד עם פרמדיק, לצד של פרמדיק בתפקיד הזה, ואחרי זה אני הייתי באוסטרליה, ואני עובד עם כל מיני דברים שם, גם כן מטוסים ומסוקים, בגלל הגודל של המדינה. אבל העבודה זה משהו דומה, שמה שאתם עושים, קצת יותר רחוק, זהו. אז אנחנו עובדים בתאונת דרכים, אפילו תאונת דרכים שזה קרוב לבית חולים, אנחנו עובדים לתאונות כאלה, ויכול להיות או זה חוף ים, או זה רחוק, או זה בבית של המטופלים, שזה ממש רחוק, או בבית חולים קטן, שזה גם כן רחוק מהמרכז של המדינה. אבל מה שזה חשוב לדעת, למזלול שלנו, שזה אני לא עובד מעל הפרמדיקים, ואני לא עובד במקום הפרמדיקים, אני עובד לצד של הפרמדיקים, אנחנו עובדים ביחד, זה הצוות שלנו, זה ככה עובד בשבילנו, ויש evidence שזה יכול להיות עובד במזלול מיוחד, שזה לא בכל העולם, אבל אצלנו זה עובד טוב, וזה עובד בגלל שאנחנו עושים את התרגילים ביחד, ואנחנו כמו high performance team כזה, ויש לנו את ה-audit and governance לעבוד ככה. אוקיי, אז עכשיו אני לא יכול להמשיך בעברית, אני מצטער, בגלל שהרמה של העברית שלי זה לא גבוה מספיק, אני לא רוצה שאתם איבוד את הנקודות החשובות, אז אני עכשיו ממשיך באנגלית. אוקיי, so, injury prevention. You can't really do a talk on trauma without mentioning injury prevention. And this little picture here is just of interest, might be of interest to you. This is Graham. This is essentially how humans would evolve if we continue to subject the human body to the forces that we currently do. So you'd have to grow a sort of fatter neck so that you don't break your neck every time you have a massive impact. You've got a bigger skull, you've got a more rigid chest, you've got springy legs and springy joints. The alternative, of course, is that we do something about the carnage of trauma, especially on our roads, and that's really the nature of injury prevention. But on to the topic that I want to dwell on a little bit more, and that's traumatic cardiac arrest. And what's really important, I think, is to define what we're talking about. So, traumatic cardiac arrest occurs when a severely injured patient ceases to produce spontaneous cardiac output. So remember that and hold that thought. Because what we know is that survival rates from traumatic cardiac arrest have been universally poor. About 2% of patients seem to survive to a hospital discharge. But what we have to understand is the first thing we have to do is make sure that we are dealing with a traumatic cardiac arrest. And what I wanted to share with you was there are a few mimics of traumatic cardiac arrest, and one of them in particular is impact brain apnea. And it's really important for us who work in the pre-hospital arena, because this is the sort of thing that you see within minutes of getting to scene, not when you get to the emergency department. This is something that you will see because you might even be driving past and somebody's been injured very short time ago, and you might get to see this. It's important to know. So it's a very interesting study they did for impact brain apnea. And that was very interesting unless you're a dog, because what they did was they took dogs and they put a metal plate on the side of their head and they fired a .22 caliber bullet at the side of the dog's head to give it a shock to the brain. And what they discovered was as soon as the impact happened, the dog stopped breathing to such an extent that it required artificial respiration, but then the natural respirations came back. But at that point, also, the blood pressure never dropped sufficiently. So this patient wasn't in traumatic cardiac arrest, but when you looked at the dog, it looked stone dead. So you think of some of the patients that you'd get to very soon after impact. They're not breathing, they look dead, but they might be impact brain apnea, which goes back to the importance of opening the airway and taking some rescue breaths in the event of what you think is a traumatic cardiac arrest, to be sure you're not dealing with something like impact brain apnea. Which brings us on to actually who is dead. You might think it's really straightforward. You're dead and you get buried, or you come back from the dead. But either way, you've got to be sure that you're dealing with traumatic cardiac arrest. And let's be clear, if you've got a patient who's bleeding to death, at some point their systolic is going to be 80 and you're going to have a weak pulse. At some point it's going to be 70 and it's going to be really weak, and then it's going to drop a little bit further. It's going to be 65 or 60, their systolic blood pressure, and you're not going to feel a thing, okay? Now, is that a cessation of their cardiac output, or is that just a low flow state? So the difference between traumatic cardiac arrest and low flow state is really important, because if you're stone dead, fair enough. There's limited things you can do, but can you be sure that your patient is stone dead? Can you be sure that it's the 2% that you were dealing with earlier not going to survive? It's not worth my time. Well, I'm telling you that I think it is worth your time to have a chance, to give these patients a chance in traumatic cardiac arrest and try and treat them. So, have we got anything to help us make the decision about whether the patient is in traumatic cardiac arrest or not? Well, we do. Some of us have ultrasound, and if you have ultrasound handy, that's a real helpful tool, and you can see whether or not your heart is in fact on the left there in a low flow state without a palpable pulse, or whether or not you're actually in cardiac standstill and arguably more likely to be stone dead. The other thing you've got is end-tidal CO2. So as you know, your end-tidal CO2 might be normally around about 40. It will go down as your cardiac output goes down, but it's not going to be down super low. It's not going to be in cardiac arrest levels where it's in single figures. You'll probably find that in these low flow states, your end-tidal CO2 is up around about the high teens. So 2 useful things you can do when you arrive to see whether or not your patient is worth a punt. Because what are we doing now for traumatic cardiac arrest? Well, a lot of the time, we're actually obsessed with this, oh, it's a poor outcome, these patients aren't going to survive. So we're not doing anything. And these patients are dying. And there's evidence in the literature to suggest that if we don't do anything, you're just going to fulfill a self-fulfilling prophecy of that being a high mortality. Whereas in actual fact, what we should be doing is, if the patient has just lost their output, or when in the back of your ambulance even they lose their output, this is a goer. This is a traumatic cardiac arrest that's worth a punt, okay? And you should start by treating the pathology that we're going to go through now. So give it a chance is the message, especially if the vital signs have only just disappeared. So what can we do? Well, you'll be pleased to know that there's absolutely no role for these things in traumatic cardiac arrest. If you have traumatic cardiac arrest, CPR is not going to help, and neither is buckets of adrenaline. So what should we do? We need to decide what we can reverse, and we need to reverse reversible pathologies in order to give this patient a chance of survival. Now, I only put this up, I don't expect you to go through it, but I put this up so you know that this is standard. This is the European guidelines. This is not something that I'm just making up to give you. This is what we're going to be running through now a little bit in my talk is already there in guidelines, and it's well worth taking a look at them because traumatic cardiac arrest is different to regular cardiac arrest. So here we go. In a nutshell, this is what we want, okay? Causes of the traumatic cardiac arrest that I can do something about. That's the important bit. Can I do something about it? All right, so we're going to follow the CABC strategy, which you know is catastrophic bleeding, airway, breathing, circulation. So catastrophic bleeding, bleeding that I can control, okay? Important, I can control this bleeding. Is the airway obstructed? We're already going to check that because we're worried about impact brain apnea. The tension pneumothorax, again, I don't dispute the tension pneumothorax data, we'll come to that in a second. And then replacing blood, okay, from the bleeding that I've already controlled, I'm going to be able to replace blood. And I'm going to touch at the end, very briefly on cardiac tamponade, a bit like Alon mentioned earlier. So, bleeding that I can control. We've got to stop the bleeding. We've got to turn the tap off. People underestimate pressure. Pressure's not cool, it's not sexy, I don't want to do pressure, it's boring. Pressure on the bleeding area will stop the bleeding. And don't be fooled by all the combat gauzes and quick clots. They also require pressure. You can apply them, but then you still have to apply pressure. Your pressure should be in place from the beginning to the end of your journey if you actually genuinely want to stop bleeding in a junctional area, for example, like the groin. Put your fist in it. Tourniquets you've already seen, and they are critical for extremity trauma and well worth it. And I just put this on because this was a guy who got his leg stuck in a wine auger. You can still buy Australian wine, it's fine, but this guy, you can see, had his CAT tourniquets applied in the field by the MedSTAR team, and we simply swapped them out for pneumatic tourniquets in the trauma room. But the job had been done by the MedSTAR team, and the patient didn't bleed to death because of the tourniquets that were applied. So this is a little slide that says note for ROSC, okay? So this is note for return of spontaneous circulation, or a note if somebody is peri-arrest. So if you think they're just about to go into cardiac arrest. If they're truly in cardiac arrest, you're not going to think too much about this. But I really wanted to stress the importance of bleeding that I can control in those situations. Also refers to adequate splintage and packaging. Pelvic binders are useful. They do apply pressure. Straightening long bones and putting traction splints on is also useful if you carry traction splints in your services. And if you don't believe in pelvic binders, you should. This is a pelvis. You don't need to be a pelvic surgeon to see that that is splayed wide open and probably bleeding like stink. And after the pelvic binder is applied, it's the equivalent of applying pressure. So you should apply pelvic binders to these patients if you're going to give them a sporting chance. All right, airway. There's been a lot of talk about airway already, and I'm not going to spend too long on it. Suffice to say that you carry laryngeal mask airways or supraglottic airways, and so you should. That is something that's very important for us to do, and we should control the airway. You can control it with position, or you can cite an LMA. Don't get hung up on intubation. People talk a lot about intubation, and I already enjoyed the question earlier about the inability to use paralytic agents hindering you, because that is true. It's very difficult to score perfect intubated conditions without rocuronium or succinylcholine. So don't get hung up on the tube. You've got a supraglottic airway, use it. You've also got the ability for front of neck access or coniotomy, and that is something that you might need to consider if there's severe facial trauma. But opening the airway to make sure that hypoxia isn't a reversible cause of cardiac arrest is important, and you should be doing that for all of your traumatic cardiac arrest patients. So let's spend a moment or two on tension pneumothorax, because we know that 25% of traumas involve the chest, and up to half of them might have a pneumothorax. The actual numbers of tension pneumothorax is hard to prove, and people get excited about it. But let me tell you, if your patient is in traumatic cardiac arrest, i.e. they are dead, you're putting them into a very small group of people that may well have a tension pneumothorax. And if you elect to treat that, what's the downside? Do you get any deader than dead? No. So if you think your patient is in traumatic cardiac arrest, you decompress the chest, because they can't be any deader. And how do you decompress the chest? Well, first, you can check with an ultrasound if you want. If you have ultrasound available, you can check and see whether you've got nice lung slide at the top or whether you've got no lung slide at the bottom. But I know needles have been bagged, and rightly so, and I'm not suggesting that you go banging needles in, but in the event of traumatic cardiac arrest, again, you can't make them any deader. And they might have a tension pneumothorax. That might be why they're dead. So it's worth treating. We know up to 40% of them will fail, and that's usually because Western diets have made us all fat, and our chest walls no longer are too thick to cater for the standard needle going through. So you can use the second intercostal space mid-clavicular line, or you can use the fifth intercostal space in the anterior axillary line, which tends to have less fat and makes life a little bit easier. The other thing you can do, but only in the event of having positive pressure ventilation. So if you've put a supraglottic airway in, or if you've intubated the patient or done front of neck access, is you can do a simple thoracostomy or a finger thoracostomy. That is putting your finger in as if you were putting a chest drain in and using your finger to keep that open during the journey. That is good enough in positive pressure ventilation. You don't need to insert a plastic tube. This is good enough. This is what we do as a standard of care for our complex traumas, and for those in traumatic cardiac arrest, they get ventilated and they get finger thoracostomies, and we bring them to the ER without a tube in situ. And in fact, in the emergency department, we don't put the tube in usually until after the CT scan. So you can manage without that if you can, but I can't stress enough that if you're not positive pressure ventilated, you can't do this because you're just creating a problem. So C is replacing the bleeding. That's the bleeding that you've already stopped. IV access, critically important, don't forget. And especially if you're giving blood, you don't necessarily want to be giving blood through an IO because it will hemolyze. So ideally, you want to try and make sure you're giving blood through an IV. And the ideal, as you've already heard already, is to replace blood with blood. Whole blood versus component therapy. If you're carrying whole blood, use whole blood. The thing that perhaps wasn't mentioned and should be is blood should be warmed. Yeah, I don't know if you're carrying blood warmers, but this MECU, for instance, is very small, very light, and lasts forever from a battery perspective, and will warm your blood from the cold that it needs to be in your bag to 38 degrees for your patient. And you should not be giving cold blood to patients, even in traumatic cardiac arrest. Again, a note for ROSC, don't forget if somebody's peri-arrest or has got an output back, you need to think about hexacapron, and also if you've been giving blood in particular, calcium as well, because the triad of coagulopathy is not a triad, it's a quadrangle, and one of them is calcium. So I'm going to finish with tamponade, because you've already heard a little bit about this from Alon, and I entirely agree in this instance. You can do an ultrasound if you've got one, if you really want to. You probably don't need an ultrasound for that top picture on the right to know that the patient's in trouble. And the patient needs a thoracotomy. If they've got cardiac tamponade, they need a thoracotomy. Now, we're happy to do thoracotomies on the roadside, both in London and in Australia, and we're equipped and trained and governed to do it. It's not something that you guys can do, but it's something that you need to know that that's what they need, because this is one of the few cases where you need to move super quick. You need to wrap everything up, open the airway, decompress the chest, and then shoot off with your patient so that you can get them to somebody who's prepared to open their chest. And the irony is, this is the most survivable of all of the traumatic cardiac arrests. If you've got cardiac tamponade, the survival rate can be 20% in traumatic cardiac arrest. Patients who are dead, 20% of those with cardiac tamponade will go on to survive if treated properly. So in summary, what have we got? We need to arrive optimistic. We need to arrive at the patient convinced that we can value add and that we can do something. You're looking for things to do, this is something that you can do something for. Assess your patient. If you've got tools to assess your patient, use them, ultrasound and end-tidal CO2, but you don't have to have them. Have you got enough evidence to say this is traumatic cardiac arrest? This isn't impact brain apnea, and I just don't think the patient's, I think the patient's got no palpable pulse because they're in traumatic cardiac arrest or they're in a super low flow state. So now I'm going to reverse the reversible. I'm going to stop the bleeding that I can stop. I'm going to open the airway. I'm going to decompress the chest, both sides, and then I'm going to get IV access, and I'm going to give blood. And then I'm going to move expeditiously to the trauma center. And I'm going to say this patient has died, because despite doing all of that, that patient didn't get an output. And if you're too far away, then that means that patient has died. So that's really all I wanted to say. We have put our experiences into a book in Australia that is Cases in Pre-Hospital Retrieval. It's designed for paramedic doctor teams, so it would suit you guys too. And it just runs through what we do in our little group over there in regards to pre-hospital medicine, retrieval medicine. Also, we do a little bit of peds and neonatal retrieval and the special circumstances. Thank you very much. אני מצטער על העברית שלי.